I think we should consider getting started. This poses to be a very interesting session. I'm Spencer King from Emory University in Atlanta, USA. My co-moderator is Young-Hak Kim from Asen Medical Center, and we have a panel. We're going to respond to the presentations. Jang-Whan, Adrian Banning, Kim-Hwan Youn, Abdullah Shihab, Shengxian 2, Gerald Wagner, and Jong-Chan Youn. So the first presentation will be from Young-Hak Kim. Subject is AI and Robotics for Cardiovascular Care.
Thank you, Dr. King. I'm very happy to present my slide in this session. The topic is application of AI and robotics for cardiovascular care. This is my disclosure. I'm involved in the company of AI and robotic startups. And I have two topics. The first one is interventional robotics for coronary artery disease treatment, and the second one is AI for coronary interventional assistance. And this system is Corpet 200, and it was firstly approved in US FDA in 2012. And the company was acquired by Siemens in 2019. The second generation release form, as you see, was released. But unfortunately, Siemens stopped the business for cardiovascular intervention last year. But it is still available for neurovascular treatment. And let's see why the company suspended the business in cardiovascular intervention. And this is one meta-analysis data comparing robotic versus the conventional manual PCI. And the robotic PCI used the Corpet system, as you saw. And the clinical success was comparable between the two arms. And the contrast volume was reduced with the use of a robotic PCI. And it was benefit to patient. And the fluoroscopic time was also reduced by robotics, but the benefit was marginal, as you see. And this is a proof of concept clinical study to investigate the feasibility of a remote telerobotic PCI. As you see, the operating room was 20 miles away from the cath lab. And the connectivity was conventional RAN system. And they did five stable patients. So they proposed that remote tele-PCI can be a viable option for the urgent situation like a STEMI in big countries like India or China, or it would be an option in the very serious pandemic infectious disease like COVID-19. So there is the advantage and the disadvantage of the current prior and the Corpet robotic system. This is advantage, and it is certain that they reduce the radiation exposure and orthopedic injuries, but it is the benefit to operator. And there's marginal potential reduction in radiation exposure and the contrast volume. It was patient benefit. And there was possibility of a telerobotic PCI, but it is not come true yet. But there's several serious limitations. The first one is the robotic system cannot accommodate the multi-vessels, multi-channels, or intravascular imaging device cannot be used because they use only one channel. So you have to use one wire on one device. By percussion stenting, CTO is very hard to be done. And the clinical evidence was still not sufficient. So the other companies in other countries are trying to develop their own system to overcome the prior and the robotic system. And the French company Robocat and made their system R1, and the Chinese company invested big money to these startups, and the clinical trial is being done in China in several areas. And the Korean startups, Adrian Robotics, recently developed their system Aviar 2, and last year it was approved by Korean FDA. And this is the Aviar 2 approved system, and it would be the commercially available hopefully at the end of this year. And there are some potential advantages of Aviar 2 compared to prior one. And this is haptic device. Haptic device is the device to manipulate the wire or devices. So we designed this one to improve the user-friendly the manipulation. And the second one, second advantage is the multi-channel. So this multi-channels allows multiple wire navigation or multiple standing. So we hope this is would be useful for complex intervention. And so we try to improve the beneficial effect to the patient. And the control model and the UI UX was also improved. And this is the first-in-man clinical study with the AVR 2. You see the operator, and this is a haptic system, and the operator push in or pull the wire back and rotate and the wire or devices. And in the screens, and the operator can change or manipulate the softwares. And this is the system with the multi-channels. So this is only one wire, but you can two wires or to stand simultaneously. And the initial registry included 200 stable patients, and that there was no crossover from robotic to manual PCI, and the clinical success rate was 100, and radiation time was significantly reduced to operator. But we need more clinical upcoming studies to improve the benefit of it with the complex population of patients. The second topic is AI for coronary interventional assistance. And the QCA is very useful for standard clinical studies, but it is not useful in the cath lab because of the complexity, and it took at least more than 10 times, so it doesn't make sense to do in the cath lab. So this is AI QCA system. It can provide you the detailed information within a couple of seconds. You don't need to spend your time. And this is also made by Korean startups, and it was approved by Korean FDA. Also, US FDA approved these softwares. And this software can provide detailed informations. And it was trained hundreds of thousands of patient angiographic and clinical data. And there was a strong correlation between AI measured QCA and manual QCA, as you see. Diameter standards, MLD reference, and the vision length was strongly correlated. Okay, and this is slides and how it works. So if the image is integrated and transferred to the software, you can see the result within a couple of seconds. So the software can assist you. The reason more approach of the ranks and assist to help your decision and which stand size or which stand diameter would be appropriate for the regions. And one big randomized clinical study was done to compare the clinical efficacy of AI-guided PCI. So this is a comparison between MPXA AI-guided PCI. So basically angiography-guided PCI, but angiography was measured by AI QCA. And versus OCT-guided PCI, the randomization enrollment was already finished. So we hope we can final result at the end of this year. And the AI FFR is also done. So we are calling it MP-FFR XA. And basically, FFR was measured by angiography. It looks like a QFFR. So if you combine the two modalities, AI QCA and AI FFR, and both systems can provide you functional and anatomical detailed information simultaneously. So this is my conclusion. Robotic PCI, we have more studies to improve the clinical efficacy, and also AI QCA was also measured by it, and the benefit should be approved by clinicians, and we hope the both system can provide us and can provide the benefit of to operator and the patient. Thank you for your attention.
Thank you very much. We'll move along to the second presentation, which is an AI application of cardiovascular imaging. The lecturer is Jihoon Kweon, who's also from the Youn Medical Center.
Thank you for the introduction. Today, I'd like to give a presentation on the topic of AI application of cardiovascular imaging. It's truly an honor to be here and share my words with all of you. I'm a consultant of Mediphysical Corporation. I have three topics. I'll present my research on database and integration, which are crucial to AI development. Then I would like to share how the technical advance in general AI accelerate the progress of cardiovascular imaging analysis. First, I would like to introduce new database for AI, ICANNET. As you heard from Dr. Kim's presentation, AI QCA provides the reproducible and reliable result in real time. To achieve this, the 10,000 patient data were used to train AI. Then the exclusion was minimized to better reflect the characteristics of real patient pool. However, there remains the challenge for expanding the database size to develop a more robust AI model. To tackle this issue, we have built a large-scale database. It currently contains 3 million angiographic frames, and we plan to increase this to 100 million in near future. The database is named ASAN Invasive Coronary Angiography Network, or ICANNET. The base model is trained to estimate missing information here in angiography. The ICANNET can accelerate AI development for coronary angiography. It reduces the amount of data needed for training and improves the performance. As you can see here, using ICANNET, the segmentation of target vessels is improved by more than 2% in average. It can also be used for segmenting the lumens in other views and different interventional devices. Ultimately, it will support the development of AI, can assist clinical decision and interventional practice. The second topic is the technology for integrating AI and AI. It has been known that the stent under expansion is associated with worse clinical outcomes. Technologies have been developed to assess whether a stent has sufficiently expanded after PCI. The 3D stent and stent boost are notable examples. Both utilize stent markers. 3D stent builds the three-dimensional structures using rotational angiography. Stent boost can enhance the contrast of stent strut by registering multiple frames in single DICOM. Using current AI QCA, stent expansion can be evaluated simply by specifying the proximal and distal ends of implanted stent. The ability to assess the two-dimensional diameter profile can be advantageous to clinicians. However, eliminating manual operations will help incorporate this technique into clinical practice. To automatically set the reference point for post-PCI stent evaluation, we have developed an AI model for stent segmentation in fluoroscopy. Recognized stent strut become challenging once the lumen is opacified with the contrast. To address this, we gathered over 1,000 images at Asan Medical Center for deep learning purpose. Our approach utilized the ensemble of 3 segmentation models. This approach had led to achieve an F1 score of 88%, significantly improving the accuracy of stent segmentation. The left image shows the AI model detecting and segmenting the stent in fluoroscopy despite the low contrast. By mapping on the stent area onto the angiography, you can determine the proximal and distal ends of the stent area. By providing reference location, we can set evaluation area for AI QCA. This task is completed with 1 second. No additional image acquisition is necessary, and it does not require changes to the current practice in cath room. In this case, stent diameter is 3.5. Based on this information, the under-expansion are found and multiple locations for this analysis. The only task required of the operator is to provide the stent diameter. This is an example of bifurcation stenting. Just like with the single stenting, the AI model accurately recognizes the stent area. The under expansion at the side branch ostium is visually obvious and easy to detect. However, the detecting second area of under expansion would like to be difficult without help of the AI QCA. This demonstrates the benefit of fully automated evaluation of stent expansion. The third topic is a technology developed not specifically for clinical use, but it can be utilized for cardiovascular imaging. The Mehara developed an AI model that segments each area based on user input. Segment anything model, named SAM. With SAM, a catheter or guide wire can be automatically segmented with just one click. It also used to determine the calibration factor required for QCA. Previously, this task required advanced image processing method, but now it only requires a single AI model. No labeling, no training, no tuning is required. This is a Metascore tracker. It tracks a path at a given location. By locating the stent area in the fluoroscopy, it can continue to track movement even after the lumen is filled with contrast. In the current state, these technologies are not sufficient to analyze all cardiovascular imaging with low resolution and low frame rate. However, AI advancement is expected to change the clinical environment in the near future. These are conclusions. We developed a large-scale coronary angiography database, ICANET, for the development of ICA-based AI technology, and we developed fully automated evaluation of stent expansion by integrating stent segmentation with AI QCA. Finally, advancement in general AI technology will support AI development dedicated to cardiovascular intervention. Thank you for your attention.
Thank you very much. The third speaker in this section is Bon-Kwon Koo, who is going to present on AI-enabled vulnerable plaque characterizations. Professor Koo.
Thank you, Professor King. And good afternoon, ladies and gentlemen. We all know that the ACS prediction and prevention is very necessary, but we also know that it is not easy. So if this patient having more than 15 lesions is destined to have a myocardial infarction, the question is whether we can pick or define the future culprit lesion using these images. And we know that it's not easy. So that's the reason why we have so many tools, including the AI machine learning technologies. And today I'd like to talk about the vulnerability assessment using CT scan, which can provide the information on local disease burden, plaque characteristics, global disease burden, and also the hemodynamics, including the presence of ischemia. In the previous Emerald trial, we tested the performance of the CT in prediction of acute coronary syndrome, combining lumen, plaque, and hemodynamic information. And in this trial, we showed that the combining lumen represented by percent diameter stenosis and lesion length and plaque characteristics and hemodynamic characteristics can improve our discrimination ability for future ACS using CT images. And today I'd like to talk about the Emerald 2 trials, which incorporated the use of AI-enabled quantitative plaque and hemodynamic analysis, what we call the AI QCPHA for ACS prediction and prevention strategy. So this study's aim was to identify CT high-risk plaque features for future ACS using AI-based analysis and to investigate the additive value of AI QCPHA to the conventional CT assessment, and finally to explore the potential implication of this tool for selecting ACS prevention strategies. So this was an international multi-center study, and we collected the data of ACS patients who underwent the CT scan before the ACS event in the interval between 1 month and 3 years. The primary working hypothesis was that the AI-enabled analysis could enhance our discrimination ability for identification of future ACS culprit lesion. And we divided the whole cohort into derivation and validation cohort, and sample size for the derivation was calculated from the data of the EMERALD-1 trial. And in total, we need 429 patients. So this is study flow. We started with the 449 ACS patients, and after screening, analyzed 351 ACS patients with definite culprit lesion. And now we have 2 key images. One is a CT scan taken before the ACS, and the other is angiogram taken at the time of ACS. And we ran 3 different core labs, and one core lab for AI CT analysis, and the other for conventional CT analysis, and third core lab for the angio analysis. And we defined all the lesions and matching those culprit and non-culprit lesions using ICA on top of the initial CT scan. And in the derivation cohort, we defined the best AI QCPA features to build the new prediction model and compare its performance with the reference model. And the same comparison was performed in the validation cohort as well. So this is conventional analysis. So radiologists are reporting the degree of lumina narrowing using CAT-RAS system, and they also report the plaque characteristics using HRP features such as posterior modeling, spotty calcification, napkin ring, and low attenuation plaque. And here's the information we used for AI QCPHA. So AI enabled us to provide the several plaque and hemodynamic features, and for this analysis, we used the 8 plaque features and 10 hemodynamic features. So baseline characteristics, mean age 66, 2/3 were myocardial infarction, and median time interval between CT and ACS was around 1 year, and no difference between derivation and validation cohort. So here is a busy slide which compared the culprit and non-culprit in CT before ACS in terms of AI QCPHA. In the derivation cohort, in all these 18 features, culprit lesion showed worse characteristics, and also in the validation cohort, except for the axial plaque stress. So it's good to have 18 features, 20 features, 30 features, but sometimes we need to, sorting out to best features to improve the clinical applicability. So for that, we decided to select the best AI QCPA features from these 18 features using hierarchical clustering and information gain analysis, and which were the delta FFR across the lesion, plaque burden, total plaque volume, low attenuation plaque volume, and myocardial mass risk. So this slide shows the performance of the conventional analysis. Stenosis severity increase, number of adverse plaque characteristics increase, the risk for the ACS increase. So it's good to know that the conventional analysis is still working. But the goal of analysis was to prove the incremental value of AI QCPA features over this conventional analysis. So in the derivation cohort, AUC of conventional analysis was 0.6. And when the AI QCPA feature was added, there was a significant improvement in predicting ACS in both derivation and validation cohort. And it's also interesting to compare whether these pure AI features can replace the human labor. So best model, AI-only model, in both derivation and validation, there was no difference. Another very interesting element, especially to the interventional cardiologist, is how do we select the treatment strategy, medical treatment or PCI? And for that, I think simply understanding the probability may not be enough. It's still good that the lesion A's probability for ACS is 10 times higher, but the other information I want to get from this analysis is the treatment target, whether it will be quantity, quality, or physiologic significance, and also time to event. And for that, using explainable machine learning analysis in this Shapley waterfall plot, you will see that in this patient and in this lesion, the primary target for you to treat is delta FFR CT, which is helpful to define your treatment strategy for this patient. And the second thing is time-dependent probability. We can generate this time-dependent probability to select the initial treatment strategy, also to select the follow-up imaging or the non-invasive evaluation strategy. So in summary, ladies and gentlemen, I'd like to say that the AI-enabled plaque and hemodynamic analysis can enhance the ACS risk prediction and the detection of the target lesion for revascularization. So integration of this algorithm in clinical practice can prevent ACS sudden death and optimize treatment strategy for patients with the vulnerable coronary artery disease. Thank you very much for your kind attention.
Thank you very much, Professor Koo. We have time for some questions from the panel. Open to
Perhaps I'll make a comment. I think the first talk about the robot doing the angioplasty is going to be beneficial for interventional cardiologists, but it's going to be hard to prove it's going to be beneficial for patients. And as long as interventional cardiologists are prepared to stand in the radiation in lead coats, that will be the cheapest and the most efficient thing. And
I noticed that there were several nurses and other people standing in the room, so it does not obviate that.
And also the remote issue, I think, is the same, isn't it? Is what do you do in bailout? And bailout could be a catastrophe if you've only got the robot to rely on. So I think that's tough. But I do wonder about things like percutaneous valve. I think the robot there could be useful.
React to that.
I totally agree with your idea that I think the prior version already proved the benefit of the radiation and the musculoskeletal problem to the operator, but we need more studies to prove the benefit to the patient. So that's why we investigate and we try to improve the device to provide the benefit to the patient. And regarding the percutaneous valve implantation, I think is more complicated because coronary artery is not very complicated lumen. It's just a small and diameter lumen. So I think the navigation is more easier. But for robotics, we need more and sophisticated arms to navigate the system for mitral valve or percutaneous aortic valves. But I think, as you said, and valve intervention would be the second target for the robotic systems.
The advantage possibly for TAVR is you're trying to do the same thing all the time. The same target. You take it from the femoral and you put it in the right spot in the heart. Whereas the coronary, every case is different.
Yes.
I'm Youn from Seoul St. Mary's Hospital. It's a great honor for me to attend this wonderful session. I have one simple question to Dr. Bon-Kwon Koo. So in your AI-enabled vulnerable characterization model, a patient demographics or data like age, gender, sex, or LDL cholesterol level, CLP level, were they included in your model or not?
The answer is no, because it's an internal control, so that the same patients, this lesion case, and this lesion control, so that our results actually are not influenced by those factors. But in an individual prediction, we definitely need that kind of information, which should be integrated in the much larger studies. But the problem is we have to include, I would say, several 100,000 patients to do that.
Thank you.
Yes.
Yes. I'm Jeon from Seoul National University. I have a brief question to Professor Kwon. Yes. Thank you for your nice presentation of your achievement. So my question is, nowadays we can use the generative AI model like ChatGPT or Cloud 3 and so on. So do you have any technology or experience to generate the virtual coronary angiography with your database and deep learning technology?
Yes. Using current generated models, for example, diffusion, stable diffusion can generate the reliable coronary angiography and other cardiovascular imagings. So we can use for the insufficient data set, we can compensate the insufficient data set or improve the performance improve the segmentation performance. And the large language model can be incorporated with the MPXA or AI QCA by just saying something. The information can be stored with large language model and provide to AI QCA, and no external action can be required for the analysis.
Okay, thank you.
Could I, before you sit down, can I ask one thing? So your images of the stent under deployment were two-dimensional, right?
Yes.
So the stents often are not deployed circularly. So do you do additional views to calculate that, or would a CT be another way to get at the under deployment of the stent using more than 2 dimensions?
You mean 3D application of the AI model?
Yeah, 3D.
Yeah, yes. I have conducted several several training with cardiovascular imaging, cardiac CT or intravascular the IVUS or OCT and coronary angiography. The 3D CCTA is more easier than coronary angiography to train new segmentation model.
Maybe I can
Because
also.
yes, I'm sorry. It's it.
Yeah, okay. So
I lost the point.
so now my question was, you were showing what looked like a 2D, and I just wondered if you were you also using a 3D assessment of
3D AI models uses same techniques with the 2D AI models, so it can be compatible. Yeah.
yeah. Fine.
Dr. King?
Sorry, maybe I can also follow Dr. King to the questions. Dr. Kweon, yes. So you mentioned also there's the application for AI for the evaluation of stent expansion. So I'm curious about to see that now by stent boost, you can see the stent structure there. You already know is that roughly that whether it's expanded well or not. But if I saw in your application you overlay the angiogram lumen on top of it. How does that can be used to help in the evaluation of the expansion? Can you illustrate that?
Why do you need the angiogram if you can see the
Yes.
Yeah.
scaffold lumen?
The stent in fluoroscopy, as is it's truly hard to segment accurately. As you know, the stent strut has low contrast, so is bypassed to analyze the stent expansion.
May I ask one additional point to this? I mean, we have a limitation with digital radiography of 0.1 or 0.2 millimeters. So in stents, we often have to work in these small margins. And decisive for stent expansion is the true vessel size. So I don't see what you give the stent, the nominal diameter, but what I need to understand stent expansion is the vessel depth, the vessel remodeling, and so on. So it's a nice tool, but it doesn't really apply or replace imaging.
Yes. In the same regard, I am developing IVUS-like QCA to estimate the real vessel size. Yeah. So in the near future, I hope to introduce my new technique to you.
Okay.
Okay. Thank you very much for the prior presenters, including me. And I will introduce the 3 remaining and the presentations today. And Roxana Mehran is the next presenter. She's not here, so she already recorded the video. So please run the videotape.
Hello, it's my pleasure to talk with you today about the individualized patient-centered learning for prediction of ischemic and bleeding risk after PCI. My name is Roxana Mehran. These are my important disclosures.
I need a picture.
When a patient presents with an acute coronary syndrome, goes to the cath lab, gets a stent, and the physician prescribes dual antiplatelet therapy, he or she is balancing the ischemic and bleeding risk and making a very, very important choice for that patient. The guidelines advocate that we tailor adapt duration after PCI according to individual ischemic and bleeding risk for every patient. There are several predictive models that have been developed to inform the clinical decision-making, but many of them have modest performance and limited applicability. But if you use machine learning, you have the potential to overcome the limitations of this standard linear prediction models by leveraging computer algorithms that capture high-dimensional, nonlinear relationships among variables from large data sets. The feasibility and usefulness of machine learning-based prognostic models in PCI patients remain unexplored. There are many, many risk models that could help make decisions. But what we did as a result used data from 11 clinical randomized studies that included about 19,000 patients to predict the probability of an ischemic or bleeding event 1 year after PCI. We measured the outcomes for major bleeding as BARC 3 to 5 and ischemic events at cardiovascular death, MI, stroke, and stent thrombosis. The population was well delineated with patients undergoing PCI with an everolimus-eluting Zion stent. The data source were pooled individual patient data from 11 clinical trials that included the Zion's stent. And we only used the Zion's arm, even if there was an important randomized study. We randomly split 75% of the data for the training data set and 25% for the validation data set. We used, as you could see, high ischemic and bleeding risk baseline features all listed here: demographics, presentation, procedural, etc. The data pooling involved the variables that are associated with bleeding and ischemic events separately. And we did this very, very nicely. The variables were common between some of the pooled studies and excluded if there was more than 40% missing. We imputed data performed with the K nearest neighbors method. The variable selection was performed separately for bleeding and ischemic events to identify the most relevant predictors using the Baruta algorithm, and the top 11 most important variables were considered in the final model. Well, if you look at the ischemic model and the bleeding model, you see that the random forest effect had the best C-statistic pretty much everywhere. And so it was the best model and it was selected for validation. And as you could see, the best performing machine learning model was tested against a predefined performance goal of C-index value of greater than or equal to 0.65 at 97.5% lower confidence interval of bootstrap C-index distribution. Both models met the performance goal, and you could see that here very, very nicely. We also very nicely assessed the performance visually via calibration plots comparing predicted survival curves versus observed Kaplan-Meier survival curves over a year. And you could see that here really, really nicely that, sorry, let me go back. That as evident in these two models that you see right here, that the two curves almost overlap. both the predicted and the actual. Look at that, how beautifully they overlap. And more specifically, the curves for predicted ischemic and bleeding risk consistently remain within that 95% confidence interval. Here's an example of a patient. You collect the data. It goes into the XDAPT calculator, and very beautifully, we're able to actually show, very, very interestingly, the calibration plots as we stratified them according to low, medium, and high risk. And you could see that here for that patient. And then we did look at this in low, medium, and high risk. And you see that right here, really nicely shown. And for each of these, we stratified the patients into distinct groups using k-means clustering based on the calculated Shapley values that you could see right here. The Shapley values are a method that's used to understand how and why a machine learning model makes predictions. So they qualify the contribution of each feature to the predicted outcome. And of course, considering all possible combinations of the features, patients were categorized into low, intermediate, and high risk. And this grouping ensured that patients in the same risk categories shared those same Shapley value profiles and therefore similar risk criteria. So it really is a very nice way that you could see this playing out nicely. Now, if we go back to our Jane Doe, you see that this patient, our patient example, based on her Shapley values, classified as a high ischemic risk, 11.8%, and a moderate or intermediate risk for bleeding, and you see that here. What's nice about this model is that you can also see the contributors of how we got there. For her ischemic risk, you see that the huge contributor was the fact that was her hemoglobin level. And I think that's an important risk predictor. And then here you see what contributed to her bleeding risk, her age, the most amount. One of the other things that we did is that we explored the intersection between ischemic and bleeding risk in our data set. We see a lot of the patients fall into this intermediate risk group for bleeding. And you see that right here. And then after the cross classification, the bleeding risk with ischemic risk groups, we found that the higher bleeding risk, the greater the probability of having also an ischemic risk. And you see that here in the high bleeding risk groups, we have quite a huge number of high ischemic risk patients. The classification, which really helps us improve our understanding of that net clinical benefit that I think is very, very important. Now, there are important strengths of this machine learning experiment of XDAP. We used 11 clinical trials. We had independent adjudication, very good sample size derived from various clinical programs, a diverse all-comers population, but the data were limited to the patients who were undergoing PCI with the Zion stent. So the generalizability to other platforms is not known, and whether the predicted ischemic and bleeding risks are modifiable with modulation of depth, intensity, and duration really remains unproven. So in conclusion, ladies and gentlemen, XDAPT is a machine learning algorithm. It was successfully developed to predict the risk of ischemic and major bleeding events at 1 year after PCI, and both ischemic and bleeding risk models met the pre-specified performance goals that machine learning tools are feasible and effective for individual risk stratification. Future studies on XDAPT should really assess the external validity and the usefulness in guiding decisions. That's part 2. How is the guidance of the decision and the management of DAPT post-PCI will be affected? And will this be a better way than us deciding on this on our own? I can't thank enough my steering committee, my co-principal investigator, Marco Balgimigli, on so many of these, Peter Smits, Mitch Krukoff, and all of the study investigators, the data science team from Abbott, fantastic team that we worked side by side on, the funding source being Abbott Vascular and the trial being registered and hopefully very soon being published. Thank you so much for your attention. Thank you.
Yeah. I'd like to introduce the second presenter in this session, and the second presenter is Akiko Maehara from CRF USA, and her topic is AI for imaging and physiology interpretation.
Okay, thank you. So, there is a two different type of the machine learning. Number one, supervised. That's use of the expert input and classify data accurately. Number two, unsupervised. Discover the hidden pattern in data without expert input. The majority of the AI for the imaging world is using the supervised. Out of the supervised, the most of the data of the imaging AI is used by convolutional neural network. And CNN, there is a three important step. One most important step is convolutional layer that's doing the filtering to extract unique feature. And you see this example, there is a multiple convolutional layer, but continue to do, and then ultimately to get final answer. This is an example using the CNN to ask IBUS lumen area, starting the regular IBUS, and you want to know the lumen area. And by looking at the whole step, you understand, looks like lumen area filtering, and then looking the lumen area future to specify, meaning there is no other data, and ultimately you see only the lumen. That's a step, meaning filtering, and then picking up the important aspect which you'd like to know. And based on this, we did the algorithm, or AI, and to analyze lumen and vessel area. And I think what is important to using the AI, you have to set up the goal that clinically makes sense. And I thought, when you measure the lumen stent vessel area, what is clinically most important is doing the correct balloon or stent sizing, or final MSA should be consistent compared to the expert measurement. And based on the AI, we see more than 90%, we have a consistent answer. That's, I thought, good. And that's now already in the Vigo 2 in the Boston Scientific. You can see the lumen area, you can see the vessel area for the entire pullback. And after finishing the pullback, you can identify what's the minimum lumen area, what's the reference, less than 50% plaque burden, and you can identify the lesion length. That's much easier. Ultron 2.0 is also very good, and that's having the AI to detect the calcium and also the EO diameter. And this case, you see the orange, that's indicating the calcium more than 270, that's already determined by AI. Importantly, they show on the angio, that's very helpful because calcium is not always homogeneous. You have to understand where you should focus of the calcium treatment. Spectral wave is also similar. Not only the near infrared, that's original characteristics, but also they implement AI to analyze the EO area as well as calcium. And then we can see the similar findings on the angio. But those are all basic, meaning lumen, vessel, diameter, stent optimization. That's a goal. But I think really what would like know additionally is really what is about new plaque using the AI. And we know multiple data showing association between the high-risk plaque and the future event. Near the IBUS in the Prospect 2 and the LLP study is very consistent data. Lipid-rich plaque defined by NIRS is more risk in the patient. Patient who had lipid-rich plaque had more risk. In terms of the OCT, combined FFR, PECTAS observation study, they show the exact same findings. So high-risk plaque is important. And that's confirmed in the meta-analysis as well. And of course, we know the PREVENT trials show some promising data which we may consider to start treating this type of lesion. Okay, but importance is how can we reproducibly answer this type of the lesion characteristics. Left-hand side is TIC4. I do think this is clear TIC4. What do you think the right-hand side? I thought this is possibly TIC4, but when we open the answer, it's not. This is thick fibrous cap. Because of the tangential drop-off, we see this type of the artificial TIC4. That's always happened. And this is a very scaring data by Dr. Feldman. He asked, 7 OCT core in the world, I was included. And then he asked, please answer OCT morphology, TQI, etc. And then gold standard was pathology. And then kappa value of the median of the 7 core is 0.22 to diagnose TQI. It's very, very bad. So surprisingly, but intra-observability to identify so-called high-risk plaque by OCT, even in the expert. So additionally, this is Minoka. It's more difficult. You see all of them is plaque rupture, but this case, you see the plaque rupture tiny. On top, there is a convex shaped organized thrombus. That's really, really tiny plaque rupture. It's very difficult to diagnose these things in the entire coronary tree. So we need some help to identify this type of the phenomenon. So there is a bunch of the data using the CNN to diagnose the vulnerable plaque using the OCT. And this is one of them from Japan. They're picking up the OCT and then corresponding pathology. Using the pathology as a gold standard, they train the OCT, and then they validate using the different subset. Importantly, this data show the accuracy is actually AI is better than the expert. The second is from Japan. This is retrospective cohort, 1,700 patients. Expert OCT diagnosis is the gold standard. Using this, they train the OCT, they train the AI, and then finally using the AI diagnosis, they show the AI can predict future event with vulnerable plaque. In terms of the physiology, it's much easier. This is a very basic pattern of the artifact by physiology. You see the aortic damping, it's typically like 5%. Distorted wave is like 4%. But you can see this is very clear pattern. You see the damping is almost straight, and distorted wave is don't like notch and smaller, lower than the distal pressure, which is not possible. So we can define this by AI. It's quite easily. So this is already published. By looking at the pattern recognition, AI can diagnose this type of artifact easily in the physiology measurement. And finally, we have the data for the so-called like virtual FFR, or using the imaging and then calculate the FFR. When you look into the detail, it's actually quite simple. So we just need the lesion length, and we need the stenosis area and normal area. Using this, we calculate multiple pressure drop and integrate it all together. We can calculate the pressure drop, which is so-called virtual FFR. So I think that finally, the goal should be like this. When we're finishing the OCT, we calculate the OCT FFR, and we analyze the vulnerable plaque using the AI. And all together, we can diagnose this is a good result, and how can we do more on the non-calcified lesion. That should be the goal. So, future direction and take-home message is using the supervised convolutional neural network, imaging and physiology AI diagnosis have been much, much progress. AI improved accuracy, reproducibility, and good speed. And I do believe the AI-derived integrated information provide better PCA optimization, and I do believe they improve the patient outcome. Thank you.
Thank you. We have time for discussion at the end of this session. Okay, and I will present the last presenter, Dr. Mamas from UK, and his presentation is Counterpoint of AI and machine learning. It has a significant limitation. A word of caution, please.
So, thank you. I really feel like a Luddite here. So the Luddites were from the 17th, 18th centuries, where they saw machines and they used to smash machines up because they didn't believe in progress. So I feel like a Luddite, but I hope to perhaps persuade you that some of the promises of artificial intelligence haven't really been met. My focus is going to be mainly around risk scoring and the use of artificial intelligence in risk scoring. I think it's too wide to criticize robotics, imaging, everything else. These are my conflicts of interest. I guess I don't have any financial conflicts of interest, but I have personal conflicts of interest. I've published, I think, 4 risk scores with artificial intelligence, machine learning, and about 20 risk scores with conventional statistical techniques, including the UK PCI risk score and the UK TAVI risk score. Now, if we look at, say, the last 1,000 years advances in medicine, according to the New England Journal, what they say is that actually one of the top 10 advances in medicine have been the use of statistics, medical statistics. And it goes, the classical experiments of James Lind on the British Royal Navy, randomizing patients to lemons versus no lemons for the treatment of scurvy, the classical work of John Snow around cholera and the spread, where with fine epidemiological work, he noticed that the spread was from the handles of water pumps, and so removed the handles from water pumps. And really, one of the things that many of us think is that machine learning models may be superior to traditional approaches. And the way that many of these studies are generated is that they take a new cohort of patients, they apply traditional models, and then they say, hey, great, we can produce an even better model with machine learning. And that's the case here. So this is a great piece of work looking at 10-year risk of heart failure. They've got already established heart failure models, and then they've shown superiority of machine learning model in this cohort. So you may say, well, okay, you've proved the point, machine learning's better. Not quite. So this is some work that we did many years ago when we were tasked with developing a UK TAVI risk model. And in this model, we looked at existing TAVI risk scores, and it didn't really work very well in the UK TAVI population. And so with a conventional approach, we developed our own model, which was even better. And this really goes to the sort of pretty fundamentals of statistics. You will always get a superiorly performing risk model if you develop it. An established risk model in a new population will always perform worse than a new model in that population, irrespective of whether you use machine learning or traditional statistical approaches. Again, this is another great piece of work. This is from Harlem Krumholtz. And, he used machine learning models, building on existing models. So he added machine learning algorithms on top of them and showed an improved performance with, quite good performance. I mean, much better, particularly at high-risk patients. But really, what's the additive value of this model? I mean, it identified 168 extra bleeding cases per 100,000 PCIs. Is that really meaningful? Also, the model included close to 60 variables. I mean, can you work this out in your head when you're doing a PCI? It's difficult. And when you look at risk models produced by machine learning versus traditional approaches, if you use high-quality studies, actually, there's no difference. No difference in the superiority of machine learning. The differences really come from low-quality studies that we see all the time published in the literature. And again, if you look at calibration is better than discrimination. Again, in good quality studies, no difference. It's only in the poor quality studies that we see a difference. The usability is important. We all know Chad's VASC score. You can work it out in your head. You're in a clinic, you see a patient, you're trying to decide, should I give warfarin or DOAC to this patient? You can work it out. This is a score that we developed, again, predicting multiple outcomes using machine learning. It's 101 features in this model. It's completely unusable. Yes, we provided the code, we provided an app on the website, but it's not really usable for everyday practice. My other problem is that algorithms are not transparent. They're a black box. You don't really have access to the codes that run these prediction models. I think in terms of traditional medical statistics, we use covariates that we know relate to the outcome and build a model. And these models are easily identifiable. You can validate them externally. I guess the limitation of these sorts of models in very large data are multimodal data. So imaging involve factors that involve imaging, factors that may involve ECGs. They're very difficult to undertake with traditional approaches. Whereas with AI, one of the problems is that the conclusions are very hard to reproduce. You don't have access to the code often that's used to develop these models, so you cannot validate it in external populations. Akiko talked about supervised model machine learning, and this is a real problem, and this is where you, as a supervisor, can fit unmeasured confounders. So this is a classical case. There was a machine learning model that was used to differentiate dogs from wolves, okay? And it performed great until we leveraged it into the real world, and it didn't work. And the reason was that all the pictures of wolves were on snow backgrounds. And so when you try to then identify a wolf, when there wasn't any snow, it was immediately a dog and vice versa. So again, the importance of accidentally fitting confounders in supervised learning. Again, for cancer, again, a very famous case where great model for identifying skin cancer. Using it in the real world didn't work. Why? Because all the skin cancer cases had a ruler, so you couldn't use it. And one of the big areas of interest, one of my areas, is amplifying disparities. And actually, when you look, and I work a lot with computer scientists, and when you look at these models, actually, the algorithm inadvertently introduces bias into the models, and so doesn't take into account perhaps data from patients from minority populations. And so you can get a very biased risk score that doesn't work very well in your ethnic minority patients. And the final thing is, do they change outcomes? This is Cassandra from Greek mythology. So Cassandra could predict the future, and she predicted the fall of Troy during the Trojan War. But she went mad because no one would believe her. And that's the really important point. We can predict all these outcomes with machine learning, but does it really make a difference? And I'll give you one example, and there's multiple examples of machine learning algorithms where they've been introduced into work packages. They identify high-risk patients. This case is in women during labour. There's been sepsis models, a whole plethora of studies. When you run this study, neutral. No benefit of using these models on outcome for patients. So I think machine learning algorithms are useful, particularly for heterogeneous data sources, so imaging, biology, and so forth, but it hasn't really been shown to be superior for traditional models. My main concerns are issues around lack of reproducibility, black box algorithm, model instability, and also the fact that they potentiate bias. And really the biggest impact or the biggest limitation is really a lack of data around whether these risk models, whether they be machine learning or traditional approaches, improve clinical outcomes. We don't have that. And when you have randomized patients by use of risk models such as GRACE, studies have been negative. So with that, I thank you.
Well, thank you, Dr. Luddite. We were here to solve all the world's problems with AI, and you've thrown a little cold water on it. Are there questions for any of these presenters? Let me start with one, since she's not here. Roxana Mehran, I guess, is not joining in. Is she? Maybe somebody else can address this. She showed this fantastic correlation between a development group of patients and a validation group, but they came from the same population, and I just don't know how fair that is. Do you want to comment on that, Dr. Mamas?
I mean, that's one of the limitations of many of the risk scores that have been published. They're always internally validated. And of course, the performance is always going to be very good in an internal population. It's when you go outside, that's when you look at the usability and utility of your risk score. But the vast majority of risk scores are not externally validated. And I suspect if they did externally validate it, the performance would be much lower than what's presented.
Okay. Yes.
Using that example, Mamas, what is society's attitude likely to be to this? If the computer says that I can stop my dual antiplatelet therapy and I have stent thrombosis, are patients more likely to accept that than if Professor Banning says, I can stop your dual antiplatelet therapy and I have stent thrombosis?
Well, of course, I could say, well, of course they're going to listen to you, Professor Banning. But I
doubt they will.
I mean, I guess, it's the whole black box algorithm, and the general public don't really understand the limitations. And so if you say, oh, this computer with, state-of-the-art machine learning tells you this, then they're more likely to follow that advice than if Professor Mamas or Professor Banning or Professor whoever gives that sort of advice.
I agree. I think society will slightly bizarrely accept the error of the computer more readily than it might the human. And maybe that's good, because that has to be the necessity that's required for the work, for example, that Roxana's doing to become useful. That unless we accept a finite amount of risk, then there's no point in defining it.
I mean, the only thing that I would say is useful in this sort of approach is often risk scores performance falls over time. Okay, so you get something called calibration drift. And many of the risk scores aren't changed. So you'll have the same risk score 5, 10, 15 years down the line, and it becomes quite useless after that time period. I guess with these sorts of algorithms, you can develop a system whereby the risk score is updated and the coefficients change over time. And I think that's one of the areas that is quite interest to me, sort of the dynamic risk scoring, the dynamic updates of risk scores.
I want to make one comment here.
Yes.
I think it's important to differentiate the machine learning and deep learning. So AI, nowadays, many people refer AI, I think, more to deep learning. So machine learning has been many years ago. So it has feature. You know the feature in advance, then use the feature, maybe combine more of them to predict what is happening. But deep learning doesn't know limited. Actually, the depths can be very deep, and I think it's like human is the model of deep learning. It's the way that you incorporate your network and also to train the data. If you build a very deep network and you have the good data to train them, I believe that you will become human. So if you don't believe that, then you don't believe human. That's one comment. And second, I want to also comment on Akiko's talk. I think Akiko saw nicely that the reproducibility in identify vulnerable plaque based on OCT is very poor, even among expert collab. And nowadays, many applications, OCT-based plaque characterization is trained by expert instead of histology, because histology data is very limited. So I think it's important to see the objective of the evaluation. If you are trained in the same collab, and then if you use the same collab to evaluate them, then only it will be accurate if the collab is good. But you saw that among different collab, the reproducibility is very poor. So I think it's important to, if you want to use experts' opinion to, or experts' annotation to evaluate the result, it's very important to use external collab, and better to use consensus external field collab to really do the evaluation, and that will give you more objective evaluation. It's my comment.
As much as we want to see what a vulnerable plaque really is and we want to understand TICFA, I'll be more interested when technologies develop so the lesion looks like histology, and I can actually measure and I can actually see how thin it is. Then I'm ready to go. So I think we're creating AI information from inadequate imaging at the present time, and hopefully that'll get better. We're nearing the end. Did you have one more question?
Dr. Maehara, I think that your presentation is very terrific. It's very useful for us. But I have one question. Actually, as an interventionist in daily practice, the IVUS is a little bit more intuitive to be interpreted than the OCT. And I think that there is some kind of difficulty of interpretation of OCT. Which one is the fibrous adenoma, or sometimes it's not easy to differentiate the exact the line of the calcification also. And so to make acceptable the range of machine learning system or something, we should make some kind of interpretation of gold standard in each each image. And so after the accumulation of the big number of images and interpretation, we can make a machine learning model to interpretation of the OCT. But I think that there's still kind of some kind of gray zone of ambiguity of interpretation of OCT. How we can overcome this kind of area?
I think we have to be practical. I think the lumen by OCT super clear. Nobody can misunderstood. And in terms of the calcium, it's really, really clear most of the time. At least we know big calcium, it really looks like calcium, we can identify as calcium. And AI can do as well. So those clear things, I think okay. But vulnerable plaque, even expert, we have the different idea. So that's really the issue. I don't think we should use those definitions to treat the patient yet. So I think those ambiguity, we have to work more. And I totally agree with Dr. Tu. We have to have the consensus data as a gold standard, or additionally, the pathological as a gold standard to make the final diagnosis.
Okay, I think we've reached the end of our allotted time. Thank you very much, all the presenters and the panel.